everyone, my name is SarahSnyder, and today I'll be presenting my Leadership and Management for Change project. This project is focused on improving the provider and triage, or what we know as the PIT process in the emergency department. This project was selected because it is one of the largest quality improvement initiatives that I have personally experienced during my nursing career. It directly impacts the patient safety, patient satisfaction, staff workflow, and the emergency department throughput. Throughout this presentation, I will discuss the need for this change, the interventions implemented, the leadership style used to support the project, and an analysis of its effectiveness. So let's get started. Provider triage is a process in which an advanced practice provider or a nurse practitioner begins evaluating patients immediately after or even during nursing triage. The purpose of the PIT is to reduce wait times, improve patient flow, and decrease numbers of patients who leave without being seen by a provider. Approximately 1 year ago, our emergency department experienced a significant increase in patient volumes. Multiple factors contributed to this increase, some including issues of neighboring healthcare facilities, EMS transport patterns, and patients just choosing to travel further to receive care at our hospital. Assessing the situation. We had to back up for a minute and assess what was actually going on here as the patient numbers increased. The need for change became evident to our emergency department when we really started to struggle managing the increased patient volumes with such a limited space. Our emergency department has 12 monitored beds, 2 of those of which are trauma bays, 1 triage room, and 1 room we call the orders room right now. As these patient numbers started to rise, more patients were being triaged and then placed right back out into the waiting area with no evaluation from a provider because there were no rooms to evaluate these patients in. A specific patient safety event reinforced the urgency of this change in my perspective. A pediatric patient presented to our emergency department and was appropriately triaged and placed back in the waiting area. The patient was placed back in the waiting area because of all the treatment rooms being occupied and the inpatient beds being unavailable. It's pretty easy to get our emergency room backed up with just 12 beds. Sometimes when the higher hospitals don't have any beds, we have to keep our critically ill patients in our emergency department. So the patient remained in the waiting room and ultimately left without receiving treatment or evaluation from a provider, not 1 but 2 days in a row because she was not critically ill enough to take a patient room monitor bed in our ER. However, on the 3rd day, she arrived via EMS to the emergency department, and we had to remove a patient out of a room to place this patient into the room because she was so critically ill. She became the pediatric code and my first patient of the shift. This was just one patient safety event. There were many others. Not that anybody was doing anything wrong or inappropriately. We just could not treat more than 12 patients at a time that could fit in our emergency department. There were no other alternatives or surge plans, anything to help lighten the load of the lobby, the patients waiting. So this project closely aligns with several QSIN competencies. The first competency is safety. What is more important than safety? The PIT will help improve the patient safety by reducing delays in patient evaluations and ultimately their treatment. This is allowing providers to identify high-risk patients earlier along with the triage nurse. The second competency is teamwork and collaboration. You can't do this alone. Everybody has to be willing and ready to go for the day to treat all these patients that are showing up to the emergency department. Successful implementation requires communication between the triage nurse, providers, emergency department nurses, administration, and support staff when needed. Intervention number 1. We really went to work on this to improve our staffing to help successfully run the PIT process. but there are still some barriers at this time. We have reviewed patient volumes and trends, worked to improve staffing levels for the physicians, the APPs, and for the nursing staff during peak hours. Currently running a schedule with a doctor 7P to 7A, 7A to 7P, 2 advanced practitioners, one from 9 to 9 during the day, and one from 11 to 11 during the day. Also added on an additional staff nurse for the 7A to 7P hour, and we are running a 9A and a 11A nurse as well. So we have the staff. We are making the PIT process work during these hours, but we need to suspend the PIT when staffing is unsafe. Some days when we have call-offs or there's not enough coverage, they're still wanting this process to work, and that's unsafe. You have to know when to discontinue the PIT process, or you have to call in more staff. Interventions number 2. These interventions are focused on improving communication and creating standardized process or protocols for the PIT. Communication breakdown can result in misinformation, delayed treatment, and inconsistency in care. Standardized communication methods such as SBAR can be used during handoffs between triage staff and treatment teams, but that's just the beginning. We are looking to have defined roles for the provider that is in the PIT process and for the nurse that is in PIT process. We want to do standardized assessments and treatments for these patients that are in the PIT process, not just what each individual person is comfortable doing in the PIT, but we need to have guidelines for treatments and for cares in the PIT. Intervention number 3 is involved with staff education and leadership support. The leadership style most closely associated with this project is transformational leadership. Transformational leadership encourages collaboration, innovation, and staff engagement. For this intervention, ongoing PIT training is needed. As the PIT evolves, our training needs to be evolving, and everybody needs to be up to date on how you are to do the PIT process. Remaining with competency validations, transformational leadership at all times. If you don't have somebody leading the group as a charge nurse or as a manager or both, things will fall apart. And everybody should be able to make the decisions, talk about it. It's all shared communication. We're all doing it together. Everybody should have a voice. Intervention analysis. Several interventions proved particular effectiveness. The most effective intervention was increasing provider involvement during triage through the PIT. Earlier provider evaluation was allowing patients to begin diagnostic testing and treatment sooner. This was reducing delays and improving patient flow and care. Future improvements. Although significant improvements have been made, challenges still remain. One of our largest remaining barriers is the size of our emergency department. Leadership has begun reviewing floor plans and discussing potential expansions, projects that can increase our treatment space by remodeling. They're doing whatever they can to help us with this project. The current plan is to create a new main triage. So the front area desk where you're greeting the patients that are coming in will be smaller, creating a larger triage room, and then our current triage room and our orders room will become PIT 1 and 2. So ultimately the patient will be come in, greeted at the front by an LPN, placed on the triage arrival. The triage nurse will triage the patient and place the patient in PIT 1 or 2 to be evaluated by the PIT providers. This will help with the patient flow from the beginning to the end. Getting these patients in, getting them triaged, getting them evaluated, and ultimately executing the orders. There'll still be a lot of movement, non-traditional, you come in, this is your room for your whole visit. No. Patients will still be coming in and out, which they don't necessarily like, but at least they're being treated. In summary, provider and triage is an innovative quality improvement initiative. This was implemented to address increasing patient volumes, overcrowding, and delays in care. Key interventions included improving staff, standardizing communication and protocols, providing ongoing education, and utilizing transformation leadership principles, and finally, improving the space for treatment of our patients. This PIT process is helping improve patient access to care, supporting patient safety, reducing delays and left without being seen, and it's required staffing, communication, and leadership to make possible. Reference slide. These are the references used to support my presentation. Thank you for your time and attention in listening to my project. I would be happy to answer any questions if you have any. And finally, I would just like to add that I'm very proud of the improvements that our department has made in implementing the PIT process and creating a better patient care area. It's not been easy. It's not ever an easy job a day in the emergency department, but this process is making it better for staff and for patients. So thank you for listening.